All right. Okay, everybody can hear me, hopefully. Well, good morning. Thank you very much for joining us this morning in Medicine Grand Rounds. For those of you I haven't met, my name's Tom Maddox. I'm in the Division of Cardiology, and I'm also the Vice President of Digital Products and Innovation for BJC, and I help direct the Healthcare Innovation Lab. And so what we do is periodically bring in experts from around the country who are doing a lot of creative things in healthcare, in care delivery innovation, and all the different ways that we can continually optimize our care. We also are co-sponsoring this visit with the Center for Advancing Health Services Policy and Research, which is based at the Institute for Public Health and is directed by my wife, Karen Joint Maddox, that you guys may know. And so we both know and are just thrilled to have Leora Horwitz join us today. Leora is a professor of medicine at NYU. She's in their Department of Population Health Sciences. And she helps direct, I'm going to get the center wrong. Tell me the name of the center. Healthcare Innovation and Delivery Science. So the right sort of collection of words that we are very interested in here at the Healthcare Innovation Lab as well as the IPH. She did her undergrad training and medical training at Harvard and then went to Mount Sinai in New York to get her internal medicine residency. She was chief medical resident there. Then she did the Robert Wood Johnson Scholars Program at Yale and was there briefly before moving down to New York in 2014. And while she's been there, she's been very well funded nationally, published extensively, and really focused on how can they make healthcare better, primarily at NYU, but obviously with lessons for us around the country. And when you look at the website of her center, you'll see that she has her hands in all the various ways that we can affect healthcare in 2024, be it population health research, digital tools, EHR manipulations, quality and safety efforts, all the myriad things that go into the way that we deliver care today and ways that we can make it better, both with the ways that we organize our people and processes as well as support it with technology. She's been very well recognized for her efforts. She's named Emerging Fellow by the National Academy of Medicine and is also an elected fellow of the American Society of Clinical Investigation. So she's going to speak to us today about some of her work and the examples, and I think it'll probably stimulate some ideas and thoughts about what we can do here as well. So thank you very much for coming out.
Thank you. It's such a pleasure to be here. I was impressed by your memorized introduction. All right, so we're going to talk about strategies for health system transformation, specifically how to create a learning health system. So what is a learning health system? A learning health system is a system in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process, patients and families active participants in all elements, and new knowledge captured as an integral byproduct of the delivery experience. I love this definition. It's literally posted next to my desk because this is the kind of place in which I want to work. And I often ask people, do you feel like you work in such a place? But I won't embarrass you, so I don't know. But at least for me, that is not routinely my experience in the healthcare systems in which I've grown up and work today. This is gigantic. This is enormous. It's sort of like solving world hunger. So we're not going to talk about all this today. We're just going to talk about one little piece, which is how do we capture a new knowledge as an integral byproduct of what we do every day? How does what we do every day translate into knowledge? And I want to first say that this is not a data problem. We are drowning in data. Our challenge is that we don't transform that data into something usable and achievable. We don't translate it into knowledge. So I'm going to give you several strategies today that we use at NYU to translate data into knowledge. And the first strategy that we use is automation as best as possible. So I'm going to tell you about a project we did some years ago with funding from the Agency for Healthcare Research and Quality. We worked with our colleagues in the emergency department and in the radiology department to try to optimize the ordering of CT angiography for pulmonary embolism. So PE, of course, is a disease condition we don't want to miss, can be lethal, can be very serious. On the other hand, it is easily confused with many, many other things, non-specific source of symptoms. We don't want to irradiate everyone who walks into the emergency room. That has complications, there's contrast, we don't want to damage your kidneys. So we want to be thoughtful about how to do this. And happily for us, there are numerous risk scores that have been developed to help people do this very thing. So we looked at our own performance to see how often were we guideline concordant, how often were we ordering CT angiography in a manner that was concordant with the various risk scores that were available. And the answer was about 2/3 of the time, which we thought was pretty poor. So we spent quite some time developing a very sophisticated alert in our electronic health record that at the moment you ordered a CT PA, it would quickly run this algorithm and say, does this person seem like they're high risk? And it would pull all the relevant data from the electronic health record and work out the Geneva score in the background. And if the person was high risk, it would be invisible in the background, and you could go order your CTPA like nothing had happened. But if the Geneva score was low, we would pop up this alert. It would look something like this. This Geneva score is 0, PE is unlikely, and there's no D-dimer. So consider possibly getting a D-dimer before ordering your CTPA. And we would default it to, or you could choose to remove your CTPA order and apply the D-dimer order instead. So we did this. And over the course of 9 months, we had 137 CTPAs that were initially ordered and then canceled after this alert popped up. So we avoided 137 CTPAs in 9 months. Some of them were switched to D-dimer, and then the D-dimer was negative, and so they didn't need to order the CTPA. Some of them they just canceled altogether. And so our guideline adherence increased from 2/3 to over 3/4 with thousands of patients pre and post. So we were very proud of ourselves. But we don't run any tests at NYU. We don't do any intervention without considering all of the possible downstream consequences and all of the various outcomes. So we also looked at the yield of our CTPAs. And we assume we're avoiding 137 CTPAs we had no reason to be doing because they were low-risk patients, so our yield should go up. We should be finding more PEs because we're doing our tests in higher risk people in aggregate. But actually our yield went from 12.3% to 10.8%. So certainly no better and possibly worse. So we looked at our CTPA order rate. We should have been ordering fewer CTPAs because we canceled 137 of them. But actually, our CTPA order rate increased from 17.1 per thousand to 18.4 per thousand, which more or less works out to 132 extra CTPAs in 9 months, totally wiping out any benefit we had from that order. And then when we looked even closer, we found that our D-dimer order rate had increased from 30.6 per thousand to 37.3 per thousand. So what really happened here is that we taught all of our ED docs, if you're even vaguely thinking about P, get a D-dimer like off the bat, otherwise you're gonna get this annoying alert and you're gonna have to go back and order the D-dimer later. So while we increased our guideline concordance, what we actually did is we trained people to order a lot more D-dimers, and D-dimers really non-specific, so a lot of them came back positive, and then people were motivated to order CTPs in people they perhaps wouldn't have done it otherwise. So we had lengthy conversations with our ED department about this, and half of the ED department was like, this is great, we're more guideline concordant, it's all good, like, let's keep it. And half the ED department was like, this is crazy, we don't want to actually be ordering more low-risk CTPs. And in the end, we turned it off. We turned it off. And so you need to, when you're doing interventions, I always start with this story because it's important to start with sort of failures and challenges. When you're doing interventions, you have to look at all the possible downstream consequences, and you have to be willing to let something go, even if you've spent a lot of time and effort on it and you feel like it's your baby. If something's not working, you have to be willing to make it stop. All right, so automation is one strategy, and we have since automated many other risk scores and things like that with better outcomes than that. Another important strategy that we use is what I have here is justified text, is collecting better data. So most of the data that we have in the electronic health record is garbage. It is copy-pasted over and over again. It's probably wrong anyway. It is just data, it's lab values, or it's radiology reports, or it's vital signs, without any interpretation, without any synthesis, without any judgment, without any knowledge, without any added value. And so we need to get better at capturing data that have that added value to it, or turning that data into data that has added value. So I showed you this, this order before. When we were building this CTPA project, we went around and talked to a bunch of doctors because we were trying to figure out how come our guideline concordance rate's only 66%, like what's going on here? And our doctors said a bunch of things. They said, guys, we're in Midtown Manhattan, we're like half an hour from JFK. People get off the plane after like a 24-hour flight from wherever, Dubai, and they come in with leg swelling, and I know they have a DVT or a PE, and travel is not in the Geneva score, so I don't trust it. Or they'd say, I've been doing this a long time, I know what I'm doing, I think this person's high risk, I don't really care what that Geneva score says. Or they would say, this person's sister and mother and great aunt all had clots, and I just think this person's like a high risk genetically. There's something like just prothrombotic about this person. Or this person had cancer 5 years ago. None of that stuff is in the Geneva score. I don't trust it. So when we built this alert, we built it to say, it's fine if you want to go order your CTPA anyway, but just tell us why. Allow us to capture in a structured fashion, because this is all pre-GPT-4, allow us to capture in a structured fashion your thoughts, your reasoning, your judgment, so we have better quality data. And so we did. We put these were really the key things that people told us about, so this is what we put in. And after this 9-month period, when we were looking at our results, we looked to see what was the yield of the CTPA in the people who ordered it anyway, despite that low risk Geneva score, and clicked one of these rationales. And what we found is that when the doctor said, I know what I'm doing here, I don't care about this low risk Geneva score, I can tell, they were right. Their yield was just the same as in the people who were ordered for a high risk Geneva score. On the other hand, people who ordered it because of a travel history, that yield was lower, and people who ordered it because they thought there was some prothrombotic state, that yield was even lower yet. Now, we turned this off, remember. So we didn't run it long enough to have statistical significance for any of these. But had we kept it going, this is exactly the kind of information we want in our health system so that we could learn from it. So we could go back and say to our physicians, listen, we have this score, it's important, like pay attention to it, but if it's 0 and you feel in your gut there's something wrong here, you go ahead and order that. You may well be right. But listen, don't put too much stock into the great aunt with the thrombosis, like that's just not a thing. It's not, we don't find that is very valuable here. Right? So we could learn from our own experience, our own patients, our own judgment, our own clinicians, and we can iterate then our risk scores and so on. So capturing higher quality data is an essential part of being a learning health system. The next thing that we learn a lot about that helps us greatly in our learning health system is thinking about defaults in a thoughtful manner. So here's your default picture if you don't bother putting a picture up on your social media. And we think a lot about how our defaults are organized. So we have a lot of other decision support alerts in our electronic health record. And one of the ones we've had for the longest is a flu vaccination alert. Every year in September, we start putting up this alert that says, responses to screening questions suggest that influenza vaccination is indicated for this patient prior to discharge. This alert shows up for nurses, and they can order or not order the flu shot. And back in November 2017 and 2018, this alert was dismissed 99.3% of the time. It fired 23 times per patient per day. 90% of our patients left with a flu shot, so I guess that's good. But we decided that was maybe not the optimal strategy. So we went around and we talked to a bunch of nurses and we said, what's going on here? How come you dismiss this alert 99% of the time? And many of them said, well, I'm just a nurse. Like, I'm not supposed to order stuff. That's not my job. And we said, no, we have a standing order protocol in this hospital. You can totally order the flu shot. That's why you're getting the alert. So we thought, how about we just change the wording of this alert to be a little clearer? So we changed it back in February of 2018, and it says influenza vaccination is indicated. Not like screening questions suggest that maybe, influenza vaccination is indicated, RN to order per protocol, no cosign required. And we thought, this is going to solve our problem. Here's what our average number of firings per patient per day looked like before. You can see it's around 23. And here's what it looked like afterwards, where you can see it's still around 23.5 alerts per patient per day. So that was a terrible failure. But by that point, it was March of 2018, and the flu season was over, and the alert was turned off. And so we decided we would come back to it in September of 2019 and try again. 2018, try again. And so in September of 2018, we came back to it and we looked at our alert. Here's our nice alert. Influenza vaccinations indicated, RN to order per protocol. And we were trying to decide what to do about it and how to make it better. And we started talking to some nurses. But in the interim, unbeknownst to us, the IT guys in the background had changed our order to only have an accept option. You could still order or not order the influenza vaccine, but you couldn't just make it go away anymore. So remember, our original one looked like this. There was an accept button or a dismiss button. So all that happened is now there's only an accept button. And suddenly, we had only 8 alerts per patient per day. Because people, when forced to actually make a decision, they couldn't just make it go away, they had to look at it and actually make a decision, more often than not ordered the flu vaccine. So we dropped our rate of, and it keeps firing until you order it. So once they order it, it stops firing. So we dropped our alerts per patient per day gigantically just by changing that one little option on the alert. And we still had roughly the same vaccination rate. But what we were originally doing was trying to figure out what to do with this alert. And so while we were trying to figure out what to do with this alert, we decided something went wrong with the way we did it before. We talked to a bunch of nurses. They told us the problem was that they didn't know how to put the order in. We fixed that. Still, we have a problem. Maybe we didn't talk to the right nurses. So we added one other thing to this alert. Just a little link that says, give us some feedback. Got a lot of feedback. Yeah, really a lot of feedback. And some of the feedback was like this: I'm a charge nurse, I'm not taking care of this patient. Or I'm the consult team, it doesn't anymore give me the option to defer, right? Sometimes we're charting urgently. Influenza is just not the priority. This interferes with critical charting. Or I already charted that the patient refuses. Now this alert was popping up every single time the flow sheet was touched. So every time someone was charting something, that was what was making the alert pop up. So we decided that January to change our alert a little more and to add some reasons for not ordering the flu shot. Again, still just this one little accept button, but now we added these reasons. And we put the reasons that people told us in the feedback. I'm not a member of the primary team, the timing is not appropriate, or the patient refused. Now, the reason we did this was not to capture the clinical judgment of the nurse here. The reason we did this is because depending on what people click as the reason, we could change the behavior of the alert. So if the person said, I'm not a member of the primary team, we would make sure that that alert didn't fire again for the next 12 hours. So that nurse or whoever it was, whatever, during their shift, would not get that alert again because they're not taking care of the patient. Timing not appropriate, we turned that alert off entirely for the next 4 hours because no matter who you are, presumably the timing is not appropriate, so we didn't want to bother people about it. And if they wrote patient refused, we permanently turned off the alert for that nurse. And so that was actually people indicated pretty often why they weren't ordering the flu shot, and most often they said it's because the patient refused. And that dropped us from 8 to 7 alerts per patient per day, so another 10% or so decrease with still the same vaccination rate. But what we noticed is that people were not updating the flow sheet. And the problem was that the flow sheet, if you put in it the patient refused, the alert will never fire again. But if you don't update the flow sheet, it'll just keep going for the next person who comes into the chart. And so we changed, in our next round, we changed the alerts one more time. We removed the option to say the patient refused, and instead we added this thing that said, click here to document that the person doesn't want the flu shot, and that will stop the alert forever. And that got us down to 5 alerts per patient per day. And because, again, people were now documenting it and turning it off forever. Now, this was all helpful to us, and I show this to you as just an example of the sort of painful, tiny micro changes that often you have to make in processes to incrementally improve. But remember, we started at 23 alerts per patient per day, and now at this point, just a year later, we're down to 5 alerts per patient per day, which is many thousands of hours for nurses. We've been iterating this ever since, just like our pet project. We're now down to 1 alert per 1.2 alerts per patient per hospitalization. So we've now made this a totally reasonable alert. But we learned one other thing. People would also give us other feedback, like, there's no reason for the operating room to be getting this alert. OR staff don't have access to flu vaccines. Intraoperative, not appropriate timing. The patient will not be receiving the flu vaccine in the PACU, and so on and so forth. And we thought this was bananas, and we didn't understand it at all. We didn't believe it. So we went and pulled some data, which we hadn't really done on a patient level before. And here's one example of many. Here's one patient who, over 3 hours, triggered 52 alerts. It fired at 10:31, and it fired at 10:32, and then again at 10:33, and then again at 10:33. Because this person was in the IR suite, and they were updating the flow sheet regularly with the vitals of this person who was under anesthesia. And when you update the flow sheet, the alert for the flu vaccine goes off. And this was not new. This is how the flu vaccine had always worked. But the people in the OR had no way to tell the IT department, like, what are you doing? Stop bothering me. And they just became habituated to, like, click dismiss, make it go away. And we, when we were doing our interviews of nurses, did not think to go and interview the OR nurses about why they weren't ordering the flu shot, so we didn't know that either. So setting this easy feedback loop, give us feedback about this alert, opened our eyes to a whole new set of things that were happening in our hospital that we had no idea about. There was no way to close that loop and sort of connect information to the right people. And so we now have this feedback alert on every single loop, on every single alert that we make in the hospital, so that we don't get blindsided like this again in the future. So collecting feedback is a really helpful way of turning your health system into a learning health system. You can learn from the users who are in your health system. So for everything that I've talked about is really easy. You don't need like a whole fancy IT department for most of this stuff, and you don't need sophisticated technology. But of course you can get more sophisticated and do interesting things with the data and turn data into knowledge through like novel and more complicated means. And so we have a predictive analytics unit that builds machine learning models and AI models to improve our healthcare. And we have 29 AI-enabled workflows currently in our hospital. So I'll just tell you about one of them. One of our biggest challenges, and I know it's a challenge here too, because I heard a little bit about this yesterday, is identifying people who are near the end of their life and acting appropriately. Nationally, 40% of people who enter the hospice program at all, and most people don't, but of those who enter the hospice program, they spend less than 2 weeks in hospice. This is not really the goal. We need to give people time to get their affairs in order. We need to give people time to gather their family. We need to give people time to decide what kind of care they want towards the end of their life, how invasive they want to be, and we don't offer that opportunity to our patients often enough because we don't appropriately counsel them when they're close to the end of life. So we decided this was something we really wanted to work on, and there are existing risk models for mortality. We have one already in our hospital that shows like sort of risk of immediate death, but again, that's not what we were trying for. We wanted to give people time. We thought trying to predict mortality over the course of a year, for which there are models, is too long. People aren't really going to make a lot of major changes if you give them a 1-year mortality. So we decided 2 months felt reasonable to us. We thought if we could really guess who was at risk of dying the next 2 months, that time period felt like enough to give people motivation to really consider what they would want at the end of life properly. So we got our PhD colleagues, computer scientists, to build an AI model to predict mortality in the next 2 months upon presentation to the hospital. And this is a typical thing, typical sort of way that we look at performance of decision models. You're used to the area under the receiver operator curve. This is very similar. This is basically the positive predictive value versus sensitivity. It's called a precision recall curve. But you can think of it for this purpose as, of the patients who die, how many do we identify here on the x-axis versus how often are we right? Depending where you choose to set your threshold, you will catch more or fewer of both of these categories of patients. And there's not a right answer here. There's no magic. There's no actual right answer. There are trade-offs. So where you choose to set that threshold for alerting depends on what you're going to do with the result. So for example, if you decide, I'm going to alert people so that they don't offer dialysis, don't offer chemo, send the person straight home, well, you better be right most of the time there. That's a big deal. Whereas if you say, I'm going to alert people to have them make a healthcare proxy, well, you don't have to be right at all. We should all have healthcare proxies, and it's a pretty low resource. So depending on how high resource and how bad it is to be wrong, that depends on where you set your threshold. In our case, we decided we wanted to alert people to think about what they wanted to do with this patient. Think about having a goals of care conversation. Think about talking to palliative care. We didn't want to tell them to stop treatment. So if we, for example, set that at 80%, meaning we wanted to be right 80% of the time, if we said this patient's at high risk of dying, 80% of them would die, we would only capture 7.5% of all of the deaths in our hospital. If we set it at 75%, we'd capture 13% of deaths, and so on and so forth. So we had to decide where did we want to set that. Ultimately, we decided at around 75%. Now, I hope that all of you are thinking to yourselves, that's cute. I'm glad you made an AI model that can tell me with certainty that people are going to die in the next 2 months. I can tell that already. And indeed, when I looked at the charts that this machine learning model is picking up, I was like, yeah, these are really obvious. And I was very skeptical that there was any point to this intervention at all. Because I don't need the model to work this well on its own. I need this model to work this well on its own and add value and add something that the doc's not already thinking about themselves. So we ran it silently in the background for a while. And we looked to see what happened to those patients who we would have flagged at whatever our threshold was. And what we found is that even though they were really obvious, only 25% of these patients had documentation of an advanced care planning discussion during the hospitalization. These were all people for whom if I showed any doctor these charts, they'd be like, yeah, this person's really high risk. But we weren't actually having those conversations. So we decided, all right, well, let's try it. Let's turn an alert on and see what happens. And the alert looked like this. It just said, hey, this patient's been identified by the mortality prediction model as having a high risk of death or transfer to hospice in the next 2 months. Do you agree? And if you agree, think about what you want to do for this patient. Think about doing an advanced care planning note. Think about consulting palliative care or geriatrics if applicable. And you could agree or you could not agree. Or you could say, listen, I haven't even met the person yet. Give me a minute. This alert only showed up for the attending physician and it only showed up twice. So never more than twice per patient. And we ran it for an entire year. And we looked to see what happened to patients. And so here you can see people who are at extremely high risk. So these are the highest risk percentile people in our model, who all have advanced care planning notes at about 25%. And here's the fraction of people that we alerted, just that's 7.5 or 13% of people that we alerted, who had extremely high rates of advanced care planning discussion notes, 2/3 of them, instead of only 1/4, higher even than the people who actually died in the hospital. And we think this is not so much that people are learning something new here, but we're giving them a little bit of reinforcement or confidence or backups to enforce their already gut instinct that this person's really very sick. So we can automate risk prediction tools and other models to help us identify who's sick. We can gather better data by capturing what people are thinking. We can change our defaults to change the way that people behave. We can implement feedback loops so we can know what's going on in our hospital. We can have fancy machine learning models to turn our data into knowledge. And finally, we can randomize stuff, which is how we learn about our clinical medicine for many years. We've been doing randomized clinical trials for clinical medicine since the 1950s when we had streptomycin trials in the UK for TB. We've been doing this a long time, and it's revolutionized the care that we deliver. We now know how to treat childhood cancer and adult heart attacks and all kinds of things because we've done randomized controlled trials on our clinical treatments. We haven't done those same sorts of randomized trials on the operational stuff we do every day, like how should we put alerts up and how should we talk to patients and what kind of messages should we send and so on. So we have been doing these rapid cycle randomized tests now for several years at NYU. And you can think of them sort of like pragmatic clinical trials. In order to do a randomized test of some operational or administrative task, we want to have a high volume of events, so we get an outcome pretty fast. We want that outcome to be short-term for the same reason, so we know relatively quickly if what we're doing is working. We want that outcome to be easily measurable. In fact, we want it to already be collected. We want these to be embedded in the way that we deliver care ordinarily. We don't want anyone doing anything different. We don't want any nurses specially collecting new data or pulling names out of hats or anything like this. So we also need a feasible randomization scheme. And we have done literally dozens of these. We have done them in every single care setting. We've done them in every single patient population. We are agnostic to disease or setting or location or patient. So we have done a number of randomizations of our flu vaccination alert. On the inpatient side, we are doing a randomized trial starting shortly looking at changing our default vital sign frequency on the inpatient side. We randomized who our community health workers were approaching in the emergency department. We randomized who was going to receive post-discharge telephone calls after they went from a hospital to home. We've randomized the kinds of things we've put in letters that we sent to patients. We've randomized text messages. We've randomized patient portal messages, all kinds of stuff. And I'm just going to show you two of them today by way of example, the ones in red. So I don't know if you have a similar program. Most hospitals have a program to call patients post-discharge for a variety of reasons, usually to reduce readmission rate, secretly, usually to make people happier about the hospital for the HCAHPS score. And our hospital, just like every other, would do this as well. But we did get to this point where we bought another hospital, and we didn't have enough people to call all the patients who were discharged. So we already were capacity constrained. And so we were able to convince the callers, hey, you can't call everybody anyway. So how about we randomize who we call so we can actually figure out if our telephone calls are working. This is really resource intensive, this intervention. I mean, we were calling every patient who went home. It's 20,000 patients a year. So we randomized this for a period of about 6 months. And we cheated because we couldn't really randomize it. We had just like some callers. So what we did is we filtered the list that they got. We filtered out all the even number medical record number people, and we gave them a list of all the odd number medical record number people, which is basically random. It's pretty random, the order in which you show up to the hospital and get a medical record number. And what we found, and we did this, and there's like 1,600 people in each arm over this 6 months, we accidentally called about 5% of people in the control arm. This happens. But we reached about half the people in the intervention arm. The readmission rate in the two arms was identical. The mean number of visits was identical. We looked at ED visits, we looked at obs days, we tortured the data in every possible way. It was identical. So our very resource-intensive telephone calls were doing nothing. But we all know the secret agenda behind these calls, so we looked at that too. So we looked at our HCAHPS scores. Would you recommend this hospital? How likely are you to recommend it? How likely are you, did you rate the hospital 10 out of 10? And the results were identical / slightly worse in the people we were harassing after they went home from the hospital. And actually our callers really didn't believe this because they really get invested in these calls and they felt like they were doing good work. And so they asked us, well, what if you just look at, we only reached half of them, what if you just look at the people that we reached? Which is not an appropriate way to do an analysis, right? Because the people who answer the phone are special sorts of people and they may be happier kinds of people, but we looked at it anyway, just to make them happy. And the answer is there's no difference there either. So we did not fire every one of our call center people. We did not fire them. This is very important. If you're going to do this kind of study where you're testing whether what people are doing every day is useful, they need to have some trust in you that it's worth doing that test because they won't be, retaliated against if it turns out what they're doing is not effective. So we did not fire them, but what we said was, this is amazing. This is great. This is an opportunity for us to redesign this whole call program because we don't have to worry anymore that if we're not doing this phone call, we're somehow depriving people of something that's really effective. So what we could do now, for example, is we could not call all our low-risk people, and we could call our high-risk people twice, or we could call people after they've missed their appointment, or we could change what we do when we do our telephone calls and have a different script. We could focus on different sorts of things, and so on. And so this gave us the opening to go on and do a variety of other projects around post-discharge telephone calls because we had this data that we didn't have before. And the reason randomization is so important in questions like this, and we've done this with our care management interventions and all kinds of things like that, is that there is huge bias in the people who accept whatever it is the intervention is that you're doing, the people who answer the phone when you call them about their post-discharge call, the people who accept your care management intervention, the people who, who respond to text. So you can never look at just the people who engage in your activity versus, some other group. The randomization is very important to deal with that kind of bias. And the other reason the randomization is so important for many of that kind of intervention is that there is huge regression to the mean. So when we're evaluating our care management programs, the people who sign up for the care management program uniformly, universally, always have less utilization after the intervention. And so does the control group when we randomize. Because if you pick out the people who are highest utilizing in that moment, they mostly regress to the mean anyway. And so this kind of intervention is really, this kind of approach has really been very valuable. I'll give you one more example. So we struggle every year to get enough people to have mammograms. And our outpatient group has been sending these messages through the patient portal to patients as they come due for their mammograms. And I would read it to you, but it would take us like the rest of this talk, right? It's really long. On behalf of your NYU care team, we hope you're staying safe and healthy during this time. At NYU Langone Health, we're dedicated to providing you with world-class medical care. None of this has anything to do with the mammogram. And then finally, we get to the mammogram part. We think you may be due for breast cancer screening. Screening's really good. We talk a little bit about the screening, and then eventually we get to here's a phone number. So we thought, well, what if we just get to the point a little faster? And this is based actually on a number of randomized trials we had run previously on telephone scripts. So we learned a lot from those, and we applied that here. And so our new message was, on behalf of our doctor, we're sending you this message on behalf of your doctor. Our records indicate you're due for a mammogram. We realize COVID might have gotten in the way. This is obviously a post-COVID project. We just did this last year. But we encourage you to schedule the screening today. To book, please click here. Let's make it really easy. Here's a link. Or here's a telephone call. There's a telephone number if you want to just call us for help. And then there's some information. And so we ran this trial for a few months. We had a couple hundred people in each arm. And the people who received this new message were substantially more likely to make a mammogram appointment or have a claim in their insurance for having a mammogram done. But even more interestingly than that, they were also substantially more likely to make any office visit. So some of them would get this and say, oh yeah, I gotta go see my primary care doc for this and for the other 5 things that, that I'm due for and so on. So it had some spillover effect to other visits as well. There's a nice write-up about this in The Atlantic, this and some of our other projects, where these sorts of minor changes are really changing the total experience of care that people are getting at our health system. And so finally, the last thing I'll show you is just, we don't have to do just one or the other or the other. We can combine these methods, which is what we do typically. So for example, when we have our fancy new machine learning models, we, as best as we can, we try to randomize their implementation in the same way that we would randomize anything else. So during the COVID pandemic, we were the first hit in the US in terms of severity. We had 6,000 COVID patients within just the first month. We were drowning in them. And none of us had ever seen this disease before. We didn't know how to handle these people. And in particular, we were afraid to send them home because we were finding, at least with that first strain, remember, people would be sick for a few days and they wouldn't really crash until like day 7 to 10. So we weren't really sure what would happen after that, like what kind of up and down there would be, and it was stressful to send people home. Whereas we were pretty good at figuring out who looked sick enough to go to the ICU. So we didn't really need help with like who's sick, but we were anxious about who's unlikely to have a problem. So we built this machine learning model just on our first several thousand patients to create a risk score for how likely somebody was to deteriorate or to actually not deteriorate in the next 96 hours. And because we weren't really sure what the right cutoff was here, just like I showed you before, we just showed all the scores, and I sort of labeled them high risk, medium risk, and low risk. And if you hovered over it, it would show you, as best as we could, what was underlying this black box model by showing you what was driving the score. And so what we did is we randomized the patients for which we would display this score. So this is a screenshot from the patient list in Epic, and here are patients who had COVID, and you could put on that list this risk score, this risk of adverse events, and it could be, medium risk or high risk or low risk, or I just got to the hospital, I don't have any data, or we would write hidden. There's data, but I'm not showing it to you. And so we looked after some time to see if this had changed the length of stay, and the answer was it didn't change the length of stay at all. And when we looked more closely, we realized it was not so much because people were ignoring the alert, it was because we had nowhere to send these patients. All right, so back in the day, like nursing homes wouldn't take the patient, SNF wouldn't take the patient if they were still COVID positive, and they were testing COVID positive with PCR for like 2 weeks, right, 3 weeks. And so they were just sitting in the hospital where everybody, was writing in the note, ready to go home, but we had nowhere to send them. So this didn't work for more kind of contextual reasons, but this is the sort of thing that we do with our models now. So what does it take to do this set of interventions? It takes top-level institutional commitment. We have a C-suite that is absolutely committed to being a learning health system that is dedicated to data, that asks for data to demonstrate value all the time, and therefore a culture of being interested in testing is what we have at NYU. It's helpful, it's not essential, but it is very helpful to have a highly engaged IT department, which we do. They are our partners in all of this work, and they get really excited about messing around with Epic just as we do. It is very helpful to have a supportive and a collaborative IRB, which we do, and we can talk later about how we think about these projects in terms of IRB. We have a core experienced champion group in our own center. We serve as the champions for this work, but essentially we only can do it if we have frontline enthusiasm and trust, which is what we are establishing with our partners. So what are some strategies for being a learning health system? You can automate things. You can create higher value data in your system. You can mess around with your defaults. You can make sure that you have feedback loops to understand what is happening in your own system. You can create sophisticated AI models. You can randomize. You can do all these things so that you can learn from the data generated through everyday practice. Thank you. CME credit. Questions?
Any questions?
So thank you for that talk. It seems like this kind of work could have a number of different outcomes. Are you actually improving care for the patient? Are you improving efficiency or reducing clicks, for the provider? Could you improve provider well-being? Could you reduce costs? How do you balance, those different potential outcomes for how you prioritize, the studies that you do?
Yeah, prioritization is always a question because we definitely have more requests than we can handle for projects. So I meet with the C-suite, this group of folk, every 3 months, always, and we talk about what are our priorities as an institution? What are we seeing as our biggest challenges? What are the areas in which our performance or our outcomes are not as good as we want them to be? And every year, those priorities change. So last year, our priorities were patient experience, where we were really struggling, and the fact that we have the highest number of new nurses we've ever had after COVID. And so we became very anxious about nurse morale, nurse safety, and we did some projects around that. So we try to focus on what institutionally is most important. one level down, we prioritize first things that improve patient outcomes, and then things that improve provider outcomes, and we pay attention to efficiency and cost too, of course.
So one question I had was for a lot of like process improvement projects, you know, as soon as we get a good number, we kind of quit and declare victory and mark it off. So like in a lot of your projects, there's this tenacity to iterate. And so in terms of your institutional leadership and, you know, kind of management system, like how do you encourage people to keep iterating and not take that 75% and declare victory?
Yeah, and especially like how do we convince our IT department to change an alert and then 3 months later change it again and 3 months later change it again and, you know, like the same alert. We walk in, when we start a project, we actually say we are not going to do this just once. Partly because almost always it fails the first time, and that's very demoralizing. So we start off by saying this is probably not going to work. But we commit, we will stay here until it works well, and then we'll stay here until it works even better. And we feel really strongly about that. I think it's very rare that there's a silver bullet that just like magically fixes everything and you're done. So we have a QI kind of mindset around these research sorts of approaches that we combine.
So I'll ask a question.
Here too.
Go ahead.
Can you talk about how you build trust with other departments and how that enables, or I guess like the strategy to go down that road?
Yes, I'm sorry, I didn't repeat the other questions. This question is, how do we build trust? We never walk into a group and say, we're here to do X. We walk into a group and say, what are your challenges? What's not working for you? What outcomes do you wish were better? What project do you think is amazing that no one else believes you and that you want more resources for, or whatever? So we design always the project from the beginning with the people who are going to be implementing it and doing it, so it feels co-developed from the get-go, so they have trust in the process. And we always start by saying, we will stick around here until we can get something that works for you. And we view failures as opportunities to use your time better and do things better, not as opportunities to, you know, make your job redundant. And so it's worked very well for us. We have people now we've been working with for 5-10 years on these projects.
So I guess one question I have is when you look back at your projects, how many involve technology, either Epic or other, as opposed to focusing more on how the people and processes are working?
Yeah, so I showed you a bunch of tech examples because they're picture friendly. But in practice, I would say easily half of our projects do not involve messing around with Epic. We did this intervention I mentioned with the care coordinators and or community health workers and the ED. We have done a lot of work around how we telephone patients, how we text patients, how we communicate with people. We've done a lot of work around helping patients sleep better by changing the time that we draw labs, by changing the time that we do vitals. We try really hard to do a variety of things, but we are lucky that we have a great IT department, so we take advantage of that. And IT increasingly is really so embedded in everything that people do, and such a pain point for so many of our doctors and our nurses that it becomes an important thing to focus on for the provider experience.
Thanks for the wonderful talk. Can you talk a little bit about getting close to this edge where your IRB starts to get antsy about whether you can really do this without informed consent?
Yeah, we spend a lot of time with our IRB. We treat almost all of these as quality improvement projects. We do not run, we run almost none of them through the IRB. And the main reason we can do that is that we are careful about never trying to test what should be the treatment. We don't test drug A versus drug B. We test processes to get what we already believe to be best practice actually implemented, which is, of course, point of quality improvement. And so while we are testing the best methods of doing that, the sort of end state, the goal is always best practice that we already know. We have spent quite some time with our IRB developing guidance, not just for us, but for our other investigators at the institution. We really sort of spec out what is the difference between QI and research, and then we have a self-certification form that goes along with this that people can tick off and say, okay, I meet this criteria, I meet this criteria, I meet this criteria, I don't meet this criteria, and that helps people put some granularity around it. But it's very gray, and so there are definitely areas that we disagree on, and in particular, our IRB is starting to get antsy about the AI models that we do, because those are starting to feel like more new sort of treatments than they are more means of helping people know what to do. And so we talked to them about that.
Any other questions?
I'm not an MD, so bear with me. Most of us grew up with computational platforms that were actually pretty done. And like the 23 alerts you had a day on something, we all have that. And we just dismiss them because they were actually completely useless. Do you see a shift in this? Like the platforms are better. Do you see people trusting them more? Or you feel that it's a new generation that grew up with better platforms that are bad?
You know, one thing we think about often, especially with our AI models, is what threshold to sort of alert people at. So for example, if I'm only alerting people to really novel things, patients they did not think were going to die in the next 2 months, and I do that only, they actually don't have confidence in the system, because every time they're getting this alert, they're like, really? This person? Whereas if I'm alerting them every time only to people who they obviously know are going to die, then they think, well, this is useless. So we have to be really careful about trying to target that so that there's just enough surprises in there that it's useful, but not so many that they don't trust the thing at all. And we've done actually quite a bit of qualitative work around this and tried to understand what makes somebody trust an alert that pops up or think it's useful or just dismiss it automatically. We have found on balance that when we design our alerts really well, in other words, they only pop up for people for whom it's appropriate. They're not 20 times a day. They're once or twice. The adoption is pretty good. Where we struggle is when they're thoughtless, as they often are at the beginning.
All right, well, please join me in thanking Leora again.